Yes, sir. Good to start.
Yeah, good evening all. Myself, Dr. Varma, working as head of the emergency department at Yashoda Hospital, Malakpet. So I'd like to take this as an opportunity to welcome you all on behalf of Yashoda Group of Hospitals for the series of webinars conducted by emergency and critical care departments on alternate Tuesdays. So as we all know that, so have been facing a lot of troubles due to COVID-19 pandemics. Then we had come across first wave, second we have been facing second wave and all. So we have seen many of our adult and elderly people have been affected by COVID-19. Then there is a hypothetical thesis that the coming third wave will affect the children. So children and matern and obstetricians, obstetric people. So it may affect on these two groups. To extend our knowledge and to improve and gain the knowledge on it. So we have two eminent speakers over here for today to discuss on this. So topic for today is impact of COVID on maternal and child health. So now I would like to introduce Dr. Srinivas, consultant pediatrician, Malakpet, and consultant obstetrician, gynecologist, Dr. Josna ma'am. So I welcome you both. So first we'll go ahead with impact of COVID on kids, children. So for this, I would like to hand over the mic to Dr. Srinivas. Dr. Srinivas, please take over the mic.
Yeah, thanks and very good evening to one and all. So we all know that the next phase is going to be that tentative and prospective, and the next way is going to hit the COVID. So we like to go with a few basics of what COVID is causing to the children. So what exactly COVID is troubling the children, and we'll have a look at what impact on the neonates even. So I'd like to go with a very quick and easy slides to make it easy for all the pediatricians and parents. It will be like a clump of knowledge giving for all the viewers who are seeing. So first we'll go with the statistics which we have recently. So myself, Dr. Srinivas Midivali, I'm a consultant pediatrician in Yashoda Malakpet branch. Going with the introduction. So what we have seen in the first wave and second wave, so the percentage of the population involved, see, as a pediatrician group, we consider it's like 18 years of age. So less than 20 years, the overall population consists of 41%. So as of the statistic data from the India, so we see less than 12% are already got infected with this COVID-19 in the second wave even. So when you see the proportionate of the death rate to the adult, it's very less when you compare to the adult death rate or elderly death rate. It's less than 2%, which we see in the less than 20 years old. So what is a bigger problem? What we are going to have to address in the next 2 to 3 months is not the acute COVID, but I can say it is a complication of the COVID called as MISC, that is called as multisystemic inflammatory syndrome in children. What is it exactly? It is because of the complication which has happened in the acute, like active cases which got involved in the second phase. What we have seen in the second phase. So going to the next statistic date. So we have a sharp rise in second wave. That's almost like we saw like 4 lakh cases in a day recently in the month of April ending and May. So equal number, the proportionate number of adults got involved and the children got involved are same when compared to, and so the number is not changed. So however, with increase in number of cases, the number of children and adolescents with confirmed COVID also increased. So we saw many number of children getting COVID in the second wave itself. Okay, so what is the many scientists and all predicting is not the active disease of COVID, like what you call as severe pneumonia causing COVID in children. What we are expecting is it's because of the complication of the COVID. That's what we call as a third wave. We may see in the next coming 1 and 2 months. So what might be the cause? The might cause is because of the reopening of schools or college, which causes more infection and more complication. So let's see how to cope up with. I'll go with the other slides. So basics are like, what are the chief complaints you see in COVID? It's as similar to your viral infection like flu infection. So mild disease may not be noticed by the parents even. It's like completely asymptomatic and mild. So you see a fever for 1 to 2 days, sore throat, pain in the throat, and rhinorrhea like running nose and cough, diarrhea and vomiting. So along with this, we don't see any fast breathing or difficulty in breathing. Then we can consider it as a mild disease. Going to the next moderate disease. So what is added to the thing is, it is fast breathing. That is difficulty. The mother notices that the child is breathing fast. So it depends on the age, how fast. It's like less than 2 months, more than 60 per minute. So mother can calculate the respiratory rate looking at the chest. If it is 2 to 12 months, it's 50 per minute, and 1 to 5 years, it's 40 per minute, and more than 5 years, it's 30 per minute. So just observing the fast breathing rate, we can see whether it's going into moderate or mild. And having a pulse oximeter at home, checking for SpO2 for 90 to 94 can be considered. And there is no signs of severe disease. What do you mean by severe disease? Going to the severe disease is the pneumonia. Like we see less than 3% or 4% of population in children, but still we see. So what are the things to be addressed? Pneumonia, along with less than 90% of saturated in a pulse oximeter, and increased respiratory rate and increased retraction. You call this, in Telugu we say that dokkal lopadiకి పోతున్నాయా. So these are the things we have to address when you see a severe disease. So coming to the life-threatening or critical, it's like completely child requires PICU admission or HDU admission, where ARDS, shock, multi-organ dysfunction, thrombosis, and again the MISC, that is multi-systemic inflammatory syndrome in children may see. So going, this is the criteria which you generally classify the infection of the COVID in children. So how to suspect? So any disease nowadays, because it's a pandemic, so any of these complaints are there in the children, just try to address the severity, what you call danger signs. That may help the child to identify early and get the treatment as early as possible. So what are these look like similar? A fever, headache, myalgia, fatigue, tiredness, coryza, breathing difficulty, diarrhea. Even see, nowadays we are seeing the added in pediatric ages, diarrhea, vomiting, abdominal pain are also associated symptoms in COVID. So please don't address. The child may present with only diarrhea and vomiting even, and poor feeding in the neonates and infants. So whenever there is a significant finding, complaint from the neonate, and rash, conjunctivitis, mucositis, these are the signs and these are symptoms for your MISC, that is called complications of your COVID. So try to understand that rash, any conjunctivitis or oral ulcers along with a fever in the child, try to address as early as possible. And going to the next. So I keep saying that this COVID is nothing like something. It's almost like a common viral fever we see in children. So most of the thing it's mimicked like a simple viral fever. So when to address? Just try to know what are the danger signs, which I'm going to tell again in the next coming slides. So whom to test? It's like we generally don't test the children until unless you have a strong suspicion of COVID in the family. So whenever you have a strong suspicion, like parents are getting affected with COVID positive, so go with the test. And as I keep saying, the most important age group is like having a comorbid, like children with a cardiac congenital heart disease, or children with chronic kidney disease or liver diseases, or any obesity or severe malnutrition or malignancies. All these children require testing. Otherwise, just wait for 3-4 days, the symptoms can spread. And most important thing to be addressed is, if your child is having a mild disease, please don't allow the child to go to the grandparents, because they are super spreaders. As we know, they spread to the adults and elderly people, and they may land into the complications of COVID. So try to restrict the child, which for like avoid the child to go entering into the elderly people who are like susceptible and high risk group. So which test we all know this, the test we are undergoing is 2 tests, which are like rapid antigen test, and the other is RT-PCR. Like this is used by nasopharyngeal swab, and don't depend on the test. As I keep saying, don't depend on the test. If there is a symptoms of any flu for the next 1 to 2 minutes, please try to isolate the child from the elderly. This is the only thing. And if your child is presenting any features of MISC like rash, fever, or any oral ulcers, and fever not decreasing till 5 days, go with your antibodies like IgG and IgM. That may be helpful to diagnose the MISC. So how to treat? I'll go fast, because this is not that it's a simple viral disease. So we'll go fast. We'll go further with the MISC. So asymptomatic, many parents keep asking us, sir, my child is having mild fever and I'm getting positive. So is it required of any test? No, I say that none of the investigation is required for the mild and asymptomatic children. Just wait for 3-4 days, the symptoms will subside. So if the fever is more than 3-4 days, just go with a simple blood test called as complete blood picture and CRP, urine test, blood cultures, and X-ray. This is to rule out the other diseases even, because we have to prevent the other secondary infections, the COVID. So get a simple basic test. So what is the treatment? I say that there is no treatment required, but if there is temperature, Add a paracetamol like 10 to 15 mg per kg for every 6th hourly. And most important for any viral fever is maintaining the adequate hydration. So try to maintain the adequate hydration, which is most important for any child in the fever. And adding the zinc for any diarrhea type of presentation. And the most important is again identifying the danger signs. This is because asymptomatic child going into severe and moderate, just looking at the respiratory rate and SpO2, you can find the whether the child is going to symptomatic or mild to moderate or severe forms. Okay, and the admission criteria, whenever you have the mild symptoms, whom to get admitted. Again, I said when the child is having chronic heart disease, congenital like chronic kidney disease or CNS involvement, hematological malignancies, better to be attached with any of the pediatrician nearby. Okay. So going for the moderate. So moderate may require admission. It depends on the child SpO2. The child get admitted in the ward or PICU. Just monitoring the SpO2, and the investigation required added with the mild diseases like your liver function test and PT-INR, APTT, D-dimer, and blood cultures. And always rule out the other common causes, which is we see in pediatric age group like dengue, malaria. Like these are the common diseases which you keep seeing. So please rule out that before considering it as a COVID. And treating it is as similar as only thing is you add up an oxygen when compared to the mild disease, and target of vaccination should be more than 94. Add an antibiotic which based on the site of the infection like azithromycin or amoxicillin. Steroids and remdesivir is not useful for the moderate to mild disease. It depends on case to case basis. Going to the severe form, this is where everyone has to address, and it's very less than 2% of population which is getting in going into the severe. The child definitely require PICU admission, and added with this we go with the procalcitonin, ferritin, and all the inflammatory markers. I keep saying that CKMB and ruling out any coronary aneurysms with a echo. So this is the additional investigation you go for the severe forms. Again, the same thing. The treatment part doesn't change, but here we can consider the steroids or remdesivir or tocilizumab based on the case to case, how the child is sick. So I'm not going to the other complications like ARD and shock. The guidelines are same. We have to protect. ARDS guidelines are same for the pediatric age group when the child is infected with any other pneumonia and with the COVID. So lung protective mechanical ventilation is ideal for ARDS, like low tidal volume we use. And shock, the guidelines are similar to the other shock. So I'm not going to discuss in further this. I'll skip this slide. So what is the dosage we use? Generally, we go with a dexamethasone. It's a 0.15 mg per kg. Maximum is 6 mg. So we give IV or oral route, which is equivalent to the prednisolone 1 mg per kg in 2 divided dose. So and duration can be 5 to 15 days. It depends again based on the child, how the child. If he is sick, we go for a 10 to days. If it is mild, we can stop at 5 years. So indication is moderate hypoxia. Whenever you see an hypoxia, better we consider it. It is also more than 2 years. Less than 2 years, still the studies are not there. So we are still prescribed only for the more than 2 years child. And anticoagulation, yes, in the severe and critical disease, we use anticoagulation like low molecular weight heparin, that is 0.5 mg per kg to 1 mg per kg based on the child, and divide into two. We gave like 2 doses. Duration can be 10 to 15 days, and I keep saying MISC will give further for 1 month even. So based on the child, we keep on saying. So severe and critical disease, moderate disease, and marked elevation and raised GM as the indication for your anticoagulation. Okay. So remdesivir, again, there is no studies. There are few limited studies which we keep going. Remdesivir is more than 2 years, and the dose is like more than 40. It's similar to the adult. If it is less than 40, then we consider it's a 5 mg per kg on the day 1 as a loading dose, and 2.5 mg per kg OD for next 4 to 5 days. Okay. Tocilizumab, again, there is no use, and we have very limited studies to use. It's like whenever life-threatening, we can't. After we call it a remdesivir. After giving remdesivir, the child is not pregnant. You can try it, but still there are no studies in the pediatric age group where tocilizumab is used. So what are not they have no role. We can say it like favipiravir or hydrochloroquine, chloroquine, ivermectin. Routine use of azithromycin. I said like if you see any bacterial infection, then add an azithromycin and rotenavir or vitamin C, D, A. It's better to prevent micronutrient deficiency. So we keep adding multivitamins. but it has not a bigger role. Discharge chronometer, again the same, resolution of clinical symptoms. SpO2 should be more than 90 for the room temperature for more than 48 hours. And I think negative RT-PCR is not required now. And follow up the child for the next 14 days and avoiding the child to going to the near elderly. So what the main topic for today I want to concentrate is this. That is called as multi-inflammatory syndrome in children. This is what we have to know and identify as early as possible to prevent acute severe illness and also complications caused by MISC. So how to identify? See, when we know the other part of the COVID, what is this? This is a complication of the COVID. So how to identify? Additionally, we see is rash, which is similar rash, which is the diffuse erythematitis or a different type of pattern of rash. You can see edema of the hands and peeling of the skin is similar like a Kawasaki disease. You generally see a Kawasaki peeling of the skin, rash, edema of the limbs. So it's near, we call it as a Kawasaki like. I'll tell in the next slide. So presenting with a shock, whether the child is having hypotension or poor peripheries or cold clammy, then consider it as a MISC with fever right now in the pandemic. Vomiting, diarrhea and abdominal pain, pain in the neck or fatigue, any liver symptoms, because all are like multi-organ involvement and altered consciousness. Consider it along with if the child is having any COVID positive or COVID antibodies test positive. So MISC can occur acute stage, but it's very rare and it can occur in the after the recovery of the COVID infection. So consider both. And what are the other biochemical markers are raised inflammatory markers, lymphopenia and raised ESR, CRP and thrombocytopenia. So this is the criteria which we see throughout the world. We have 3 criteria, but I would like to concentrate more on WHO. This is the RCH UK guidelines. So we'll go for the WHO guidelines in the. So which age group we have to suspect MISC? It's like 0 to 19 years, more in more than 2 years to 2 to 10 years. So what is the first criteria should be present is for more than 3 to 4 days. Is the should be present. Along with that, the child has rash, which is bilateral, bilateral, and you may see a conjunctivitis, which is non-purulent, and also rash or oral ulcers in the mouth, hypertension or shock, and the same thing. The most important is echo finding. If you see any echo coronary artery changes, then you can consider it as one of the clinical feature of the MISC. Then coagulopathy and acute GI problems, diarrhea, vomiting, pain. Along with this, your high inflammatory markers, procalcitonin. As I said, any of these, and first rule out the other other bacterial infections, which most commonly you see. After this, go for your antibody test. If the antibody test, consider strongly it as a MISC. Okay, this is the WHO criteria. So how to classify the MISC? We have 2 phenotypes. One is Kawasaki disease like, the other is non-specific. So Kawasaki it's very easy to identify for every pediatrician because we keep seeing Kawasaki disease. So it's almost similar. So there is no other criteria which is changed compared to. So it's just because of COVID, we call it as a Kawasaki disease like MISC due to COVID. So the classical KD present with fever for more than 5 days or any of these 4 to 5 clinical features. One is erythema, cracking of the lips, strawberry tongue, erythema of the oral and pharyngeal mucosa, bulbar conjunctivitis without exudate, rash, maculopapular, diffuse. There are different type of rash. And erythema, edema of the hands and feet. And this is the most important is periungual desquamation, which we see in after 1 to 2 weeks of the day. So once the child got infected and if you see any desquamation after 3 weeks, then consider it as a complication and please show to the nearby pediatrician, which can pick early. And cervical implant, usually unilateral. So non-specific, as I keep saying, you don't find anything. The child may present with shock, the child may with high-grade fevers, without any of this above stated. So we call it as a non-specific multi-inflammatory systemic syndrome in children. So again, this is the same thing. We can, based on the severity, we can classify physiological severity, how to identify. The child coming with a cold peripheries or hypotension, they consider it as a severe form of MISC. Hematologic, high CRP, more than 100 or 150, and raised troponin, elevated pro-BNP, high lactate, high ferritin, high D-dimer. All these are the severity markers for your MISC. And abnormal cardiac features, again, that is abnormal ECG and coronary artery aneurysm or left ventricular failure. These are the severity denoters in MISC. So what do you do once you find the MISC? So what is the investigation? It's a similar to the other investigation. Get a confirmation with your antibodies, and added we do is like ultrasound. Ultrasound we add with along with the investigation which you do with the severe COVID disease. Tied to the most important is please try to do 2DOK in the first week to second week, because you can see at least mild changes in the coronary arteries where you can pick early and start off IVIG, because IVIG has a wonderful function on the preventing the coronary arteries. If you start early, we can prevent coronary arteries as we see in Kawasaki disease. Okay, going for the next. And this is the chart which we keep seeing. So how to approach? Once you have the features of MISC, just go with the investigation required and find out whether the child is presenting with life-threatening shock or not. If the life-threatening, go with the tier 1, tier 2 investigation, which I mentioned at a time. If it is not, first initially do with tier 1. If it is positive, then go with the tier 2. It's just to find out severity and make the commercially, like what you call financial, decrease the financial burden. You have to follow. But if you suspect MISC, better to go with all the investigation required. And always put in the mind, consider alternate diagnosis for MISC even. So what are the differential diagnoses which I want to put is Kawasaki disease? It can be because of any viral disease, septic shock, macrophage activation syndrome, viral myocarditis, because you see viral myocarditis similar to your ejection fraction failure in children, and very, very toxic syndromes. Okay, what is the treatment you keep? So what is this is also based on the phenotype, because I said like if the child is present with Kawasaki like disease, we go with the IVIG, which is like what do you call a magical drug which prevents, and you see a lot of improvement. So what is IVIG? We give 2 grams per kg consecutively, 1 gram per kg on 2 consecutive days. So it's better to give within 10 days of the fever or inflammation, because it prevents a coronary artery aneurysms. And moderate use of aspirin. Moderate dose of aspirin, you can go to 80 to 100, but based on the what do you call aneurysm, you see any complication like aneurysm or raised D-dimer, then we go for high dose. Otherwise, you go with a low dose aspirin, that is 3 to 5. Okay. So again, the management is based on the shock or no shock. The only thing is you start the protocol of the shock. You start with the giving the fluids and check for the pulsations and hypotension, and never forget to start using low molecular weight heparin, which is most important even in the children's age group, because as we know, COVID is more of autoimmune and causing thrombosis. Your low molecular weight heparin will prevent thrombosis. So start as early as possible if you suspect MISC. So again consider, because we start with a mild low dose methylprednisolone in the children with a shock. So when you think it is a life-threatening and rapidly progressed child is not improving, then it's better to go with a pulse dose, that is 10 to 30 mg per kg. But I keep saying, if the child is getting improved in the first 2 to 3 days, it's better to taper the dose, and repeat IVG can be considered. And the other drugs it's in the investigation phase, like Anakera, which we keep using for adults. Infliximab and tocilizumab. I don't think it's approved in the pediatric age group. So better. And till now, we saw that many children got improved with the methylprednisolone repeat IVG. So the same thing, first line, they always go with the IVIG, second steroids, and third is the infliximab or your high dose of Anakera. So what are the team involved? Because it's the teamwork, we require an infectious disease specialist, a PIC intensivist, and immunologists like rheumatologists and cardiology to rule out your cardiac diseases, and always take an endocrine opinion, because he keeps starting the steroids. So it's better to taper the dose along the help of endocrinologist. So how to discharge? We all know that once the child got improved, so this is most important criteria I feel, because whatever the trauma happened during the MISC, it should be followed up. So most important is echocardiogram, because once you don't see any aneurysm, it doesn't mean that the child will be normal. So always go with the follow-up. How to follow up? Repeated clinical indicated every 2 to 3 days until myocardial dysfunction or coronary artery size is stabilized. Once you see any aneurysm, so it's better to monitor for every day in the first 1 to 2 weeks and next 4 to 6 weeks till 6 to 12 months. So it's more important the child should be on follow-up till 1 year if there is aneurysm. If there is no aneurysm, it's better to repeat 1 to 2 weeks in the first 1 month, and 4 to 6 weeks in the next 6 months, and monthly after that till 12 months, because there are high chance of child developing aneurysm. It's the same we see in the Kawasaki disease. The follow-up of 2D is similar to your Kawasaki disease. Okay, next. So I'll finish up very soon. So every day we get a question like, if the mother is positive, whether we can feed. So maybe our colleague Dr. Josna will tell you more about that. So I'll brief it. Coming to this, the most important question is whether we can feed the baby. Yes, absolutely, you can feed the baby following few guidelines. So breastfeeding, grooming, kangaroo mother care should be encouraged in all children. It doesn't mean that. I'll tell what are the precautions to be taken during feeding the next slide. And they keep asking us about vaccination. If how we can go with the vaccination. See, if the child has a mild symptoms, the child if the child has a positive COVID, just delay for 4 to 6 weeks and just take your routine vaccination. If the child is not positive and there is no symptom, you can go with your routine immunization schedule, because it doesn't alter it doesn't harm the child. Better to give as early as possible whatever the routine immunization schedule to all the children even in the pandemic. So late onset, it's very rare. I don't want to go with it. Sometimes the child can present with 2 to 3 weeks, because we have few cases, we studies where you see misc in neonates and thrombosis in neonates even. So just put in the mind, if your child having any abdominal distension or not taking the feeds, or is present with any rash in the after 2 to 4 weeks after the delivery, or positive mother who got delivered, so always consider it as a late onset COVID. So again, the same thing, if the child, this is a flow chart which I want to tell. If the child or mother is sick, always in both cases, take the child to the NICU, just monitor for 1-2 days. If the child is absolutely normal, no need of testing or anything. Okay, I'll skip this. It's the same thing. Well baby, I keep saying, no, well baby, you no need to do. If the baby is doing fine and absolutely normal, at the term baby, no need to. Just give the direct breastfeeding with the triple layer mask, hand hygiene, obviously, rooming in with the mother, except while breastfeeding. So take put the baby in the other room or something, except the milk. These are the possibilities where you can avoid the infection if the baby is negative. And one attender with the mother is recommended to assist the baby care. So feeding as direct breastfeeding is recommended with adequate bearing, and there is very low rate of infection with breast milk. So it's advisable to give breastfeeding. This is the same thing, management protocol. Only symptomatic child require oxygen supply. If the child respiratory distress is more, we go with the CPAP, and ventilation, which is very rare, less than 1% you see. So I'll skip these things. So how to protect, this is the other topic we keep getting every day in our practice. So how to protect? See, first thing is, child doesn't go to any of these things. So avoid gathering, avoid child to take to the parties or functions nearby in the next 2 to 3 months is the best thing you can do to avoid your child to get infection. Once you are positive, try to avoid the child and use the mask, hand hygiene with prevent. Next is usage of mask in less than 5 years is difficult, but you can make it as a fun, making them using a mask for the next 1 to 2 months. And the most important thing is, I always believe is it's better to get vaccination for the parents. I consider it is the very strongest thing to prevent COVID infection or complications the next 2 months. If you vaccinate the parents and the caregivers who is taking care of less than 15 years or 18 years, is the best way to prevent the infection, because there are less chances the child get infected other than from family members. So again, this is a topic which keeps saying, what is it different when you see that COVID infection in second wave is because of triple mutant? As I say, absolutely. Because triple mutant is they call it as a variant of concern. The name itself says it is a concern, because the strain we call it as B1617. It has spread more easily than the original virus. When you see more easily, more number of population will get infected, more number of population, the proportion of getting sick also increases. So that is the reason we call it as a variant of concern. So will it change in the pediatric age group? I don't think it doesn't has any specific significant, but the rate of infection is more. So it's better to avoid the next 2-3 months to getting contacts or getting gathering. So many people consider that even the whatever the present vaccination available in India, like Covishield or Covax or Sputnik, it's preventing even triple variant and it will prevent the severity. So no, don't believe in anything that vaccine is not preventing. So scientists believe that most vaccines should reduce the severity of the infection, irrespective of the variant, whatever the variant, because the core protein is the same. So it will definitely prevent the child going to severe form or a critical form of the COVID infection. So it's better to get vaccinated whenever the nearest possible is available. So what is my take home message to all the parents or the pediatricians or practicing? Identify the danger signs. Fever for more 5 days, consider it as a danger sign. Rapid breathing, I keep saying fast breathing. Oral intake, again consider it as dull activity, consider it as cyanosis. If SpO2 is less than 94, think that child is present with pneumonia. Decrease urine output, again consider it as the child is having a hypotension. So dry mucosa, sunken, all are the dehydration signs. Rash, conjunctivitis, peeling of skin are the signs of MISC. So please put this in your mind before considering because we all know that the child is positive. We know that the child is positive with the COVID report. So put this mind. If any of these things are this, please address to the nearby pediatrician. It will definitely help your child to treat well, and he will be coming out of the complications next. Thanks for giving this opportunity. We took all these things from the recent guidelines, which from the AIMS PGA. Thanks for giving this opportunity.
Thank you, Dr. Srinath, sir. It was like an informative, extensive, elaborative talk. So thank you very much, sir. So have a few questions over here. Then we'll take up the questions later, sir.
Yeah.
So now I'd like to introduce Dr. Josna ma'am, who is consultant obstetrician gynecologist. So, ma'am, would you please take out the mic?
Yeah, thank you, Kiran sir. I'm Dr. Jyotsna, working as an obstetrician and gynecologist since 6 to 7 years since in Malakpet, Yashoda Malakpet. I'm going to talk about a topic which is very common to everyone. I mean, we know what is going on around us since 1 year. So it is COVID-19 infection in the pregnant women. And what is this COVID-19 and why it is very important to discuss this topic today. So we all know that with regard to the COVID-19, how it is getting transferred to the mother and to most of the family members or most of the people. They wanted to know if mother is getting infection regarding this COVID-19, is the baby affected inside the womb? So when it comes to
please make it a full screen slideshow.
Slideshow.
When it is coming regarding this transmission from mother to the baby, whether it is getting transmitted or not, still there are so many research has to be done. But with regard to the vertical transmission during the antenatal period, the probability is very less. So on what basis we can tell that there is the probability is less is at present there are no recorded cases of vaginal secretions being tested positive for the COVID-19. So why the vaginal secretions have been tested is like during the vaginal birth, or most of the mucosal secretions might have the COVID-19 virus. So when the vaginal secretions being tested, there are no COVID-19 being seen in most of the women. So we can come to a conclusion that if mother is infected, most probably the baby might not get infected inside the womb. Yes, baby might get an infection once the delivery is done, once the mother takes the baby in her hand, and when mother is feeding the baby, at that point of time, the newborn baby might acquire the infection. But as long as the baby is inside the mother's womb, most of the time there is no vertical transmission is very less. Vertical transmission is infection from the mother to the baby in the womb. So there is probability is very less. And at present, no breast milk secretions are tested positive most of the time. So when most of the mothers immediately after delivery, they will say that I'm positive, I'm COVID-19, I'm positive. So can I feed my baby? Will the baby get an infection because of the breast milk? No, there is no no breast milk was seen positive for the COVID-19. So mother can happily feed the baby by putting a double mask. only she can handle the baby at the point of breastfeeding. The other time, some other caretaker, if they can take care of the baby, that is well and well. Otherwise, only during the breastfeeding, the mother who is in active infection, she is tested as positive. Yes, she can feed the baby by putting a double mask and just feeding the baby and handing over the baby to a caretaker. And when coming to the antenatal period, I mean, like most of the women who come to walk into the our outpatient department, most of them, they will say, I am positive. So do I have a chance of getting a miscarriage, or my pregnancy may get aborted? So as of now, many women out of 10 women walking into the OP, around 5 to 6 women are being tested positive COVID-19. But as long as they are positive, and as long as their 2 weeks of their isolation is done, their quarantine is done, most of the women are very safe, and they are not getting any complications other than simple symptoms like cold, cough, and fever. Otherwise, nothing to worry about the miscarriages if they become COVID positive. And still, and the other question which is being almost being asked by every couple who walks into our OP is the virus teratogenic? What is meant by teratogenic is, like, once we become COVID positive, we take certain other drugs, like, or otherwise, if mother was little bit serious and she was admitted in the hospital and she was given some drugs like remdesivir or steroids, after giving that, is my baby will have any other complications, like she might have any other cancers, like blood cancers, or any other cancers like bone cancers, brain cancers, any other cancers, my baby can be affected. Then it is a simple thing. Still, there are no evidences, because we are facing this virus since last 1 year. Since last 1 year, who has become positive, mothers who have become positive, they have delivered healthy babies, and the babies are coming to, whenever they come to the pediatrician, they come and talk to us also, like, my baby is doing fine, she is doing fine, or he is doing fine, and we don't face any problem. So still since 1 year, we are able to see only the normal problems what a baby will have, like a normal cold, cough, and fever. Otherwise, we are not able, we can't find such cancers or anything. We should not be scared of such things, like if you get treated with remdesivir, or if you get treated with steroids, that your baby might have. No, because remdesivir, yes, it is an indicated, as well as the steroids which are being given during whenever mother gets an admitted, like an inpatient, and she's been given a steroid or a remdesivir, there are no such effects on the baby as they have those doubts, like, is my baby will get any cancers in the future. Most of the women, they come and they say, like, I'm having severe cough, severe cold, so I wanted to get an admission done. Then a CT scan is done, CT chest is been done. So most of them, they know that CT scan is nothing but a radiation. So if that radiation is being exposed, we heard that because of the radiation, or because of the number of ultrasounds we go on repeating on a COVID-19 positive patient, they have similar doubts, like, if we get exposed to CT chest, or if we get exposed repeatedly to the ultrasounds, if we are being drawn blood many times, do my baby have any of the side effects? So most of the time in our Yashoda Hospital at Malakpet, we shield the abdomen, and we are doing the CT chest especially for the pregnant women, because whenever a woman comes very late after the onset of the symptoms, like if she comes
Doctor, one moment, please check
Yeah.
your PPT. Our presentation is not make it a slideshow.
Oh, okay, 1 second. Hello.
Yes, ma'am. Good to go.
Yeah. So most of the women, they have this doubt that if the CT scan is done, they have these issues. So we shield the abdomen so that the radiation will not, the baby might not get exposed to that radiation. only the mother's chest will be exposed, so that the team of doctors like pulmonologists, as well as the intensivist, as well as the ER physicians, they have to see the chest, CT chest, and then only we can come to a conclusion. Is there a severe disease, or is it a moderate, or we can send the patient happily home? What can we do with what kind of a treatment can we give to a mother? So most of the mothers are getting panicked after they are advised a CT scan. So once a CT scan is done, once we shield the abdomen, there's no point to get panic regarding the radiation. And and most of the women, whenever they come, they get panicked, like do I need to go for an abortion, because I was admitted in the hospital for 10 days, and I was given oxygen. I was on oxygen for several days, and I was like in the ICU. So I wanted to abort. I want to abort this pregnancy, or should I get aborted because I had several injections or several drugs were injected to me? So do I need to get an medical termination of the pregnancy? As of now, there are no indications of medical termination of pregnancy in COVID-19. As long as the baby, as long as your tests are being routinely done, and your ultrasound is showing the growth of the baby is normal, and if you're doing well, nothing to worry, there is not an indication of medical termination of pregnancy whenever a mother becomes a COVID positive. And all COVID positive mothers, most of them, they will ask why we need to get an RT-PCR done, and why a prescription is needed. Most of them, they're taking a virtual consultation whenever they are having a cough, cold, and fever, and they're simply walking into some diagnostic centers, and they're asking for RT-PCR. So unless it is advised by a physician or any of the doctors, the advise an RT-PCR, most of the time it is not done. Why? Because all the maternal, regarding a mother's health, all the documentations, even at Yashoda also, for each patient comes for an ultrasound, or any patient gets registered, we have to send all these details to the state government, health department. So all COVID positive mothers' information has to be given to the state the health department, and also we have to keep our own record, because it is very important that so and so patient was admitted, so and so patient we have seen in the OP, she was done a CT scan, she was done an ultrasound. So all these are very important whenever a COVID-19 mother walks into a hospital. And next, whenever a COVID-19 positive patient comes, we have to take a proper history. She comes with normal symptoms, like the routine symptoms of COVID-19, like fever, cough, cold, or vomitings, anosmia, loss of taste, loss of smell. And most of the time, these are the common symptoms. Even the mothers or even the pregnant women are having the similar symptoms. So we have to take the normal history, and we must ask a travel history. Like most of the women will travel from one place to another, and they might travel in a normal public transport. They might not travel in their own car or in their own transportation. So whenever they travel, we have to ask for a travel history, whether they have traveled recently. So if there is a travel history, one of the family members is having the similar symptoms, then we have to take her into consideration that she might be COVID positive. And so that we can tell her all the precautions before that, because you have the symptoms which are similar to COVID-19. So you have to take all these precautions. So, and we also must ask all these women that whether any of her family members were positive, and she was with them, or she was with them most of the time throughout this quarantine time. And we should ask about the specific symptoms of COVID-19. And or otherwise, many women, they come from certain areas like which are by the government, they are labeled as red zone, orange zone, or green zone. Suppose if a woman walks from a red zone, so we can get that high alert that, okay, she's coming from a red zone, so most of the time she's having a cough or cold or fever, so we can advise an RT-PCR or a rapid antigen as soon as she walks into your OP, or as soon as she comes to her emergency room. And about her immunocompromised status, like if she is having a human immunodeficiency virus type type 2 positive. If she is positive, then we must definitely take her into a very, very high risk, because already pregnancy itself is an immunocompromised state. And upon that, if she is on a dialysis, if she's having a chronic kidney disease, or if she is an immunocompromised status like HIV 1 and 2 positive, then we have to alert her, and we have to consider her as a very high risk. And if we have to inform the patient, like depending on her symptoms, we do a RT-PCR, we do a CBP, we do a D-dimers, and if at all we want to see if she's having severe symptoms, we would go for a CT scan, and then we would like to see her lungs. And we have to inform the same thing to the patient, that if mild symptoms are there, nothing to worry. She can happily go home, isolate herself, quarantine herself, take a normal, if she's having a fever, a Dolo 650 or 500 mg is sufficient. If she's having a cold, to suppress the cold, we can give a Monteclast with some levocetirizine, and she can take her routine iron and calcium supplements as well. That's all. If she has a mild symptoms, she can happily stay at home. But if she has little bit of moderate to severe symptoms where she is unable to breathe, she's on an oxygen support, then definitely we have to admit that mother, and we have to take care of her. And at the same time, if a mother comes in a labor, if she comes in the OP, she is not in labor, she's happily, she's not having any labor pains. But if she walks in labor, if she comes with a labor pain and she doesn't know whether she's COVID-19 positive or not, still and she has the symptoms like she is having cold, cough, fever, and at that point of time, we don't know whether she's positive, whether she's not positive, because RT-PCR takes around 24 to 48 hours to get those results. Sometimes even doing a CT test at very early onset of the infection, sometimes the chest must be clear. Even in the CT scan, we might not see any infection, but she might be a carrier, or she might be carrying the infection. So at that point of time, we should counsel the family members as well as the mother, because if she's coming from a red zone, or if one of her family members was recently positive, she might be positive. So once the RT-PCR comes, she report, then only we can decide whether she is a COVID-19. But still, we have to label her if she's having the severe symptoms of fever, cough, and cold, and then we have to counsel the family members as well as her that she might be COVID-19 positive. And as she is in labor, we have to take all the precautions, all the protocols that has to be followed for a COVID-19 positive patient. So we have to wear a PPE, and then we have to take her to a labor room, and in the labor room, the labor room protocols have to be maintained as the protocols we take it for a COVID-19. Everyone in the labor room, including the diamas, including the nursing staff, including the pediatrician, including the staff, including the obstetrician, we all wear a PPE, and we have to conduct the labor if she is in labor. We cannot deny a mother if we don't have any reports. There is no RT-PCR, there is no CT scan, she is in active labor, she has all the symptoms of typical COVID-19. We cannot deny such patient that she's not, we don't know whether she's positive or not. So how to handle this women? No, we can simply take all the preventive measures what we are taking for a COVID-19 positive patient. So take all those measures. We have to admit her, we have to tell them that she is positive, she might get, her condition is in normal condition, she might get more deteriorate herself once she gets admission in 1 or 2 days, because once she is deteriorating, then the problems will start. Like many of them, they think like she just walked in, she did not had anything, because at any point of time, that cytokine storm which is going on in a mother, because already pregnancy itself is an immunocompromised state. Upon that, this COVID-19 infection, another thing, and this cytokine storm which undergoes in a mother cannot handle the cytokine storm once it is at its peak. The cytokine storm goes its peak. The mother might not take that because of her immunocompromised state. So any mother, any maternal mother who is in labor, not having the typical symptoms, we have to conduct the labor, and we have to monitor her saturations. We have to monitor her chest, we have to monitor all her D-dimers, everything, and we have to keep on counseling the family members that her condition might get deteriorate at any point of time. So this is what if she comes in the labor. And if a woman is not in labor, how do we how can and she is at a very far distance, she wants to come to the antenatal visits, but because of the lockdown outside, she can't come travel, there is no transportation. At that point of time, Yashoda Hospital people are organizing a virtual consultations for all those patients, all the maternal mothers. We are having a virtual consultation. So at that, in virtual consultation, most of the time we know our patients very well who have they have come to the antenatal visits. So most of the time we recognize them, or previous reports we are seeing, and we are guiding them what they can do and how to be away from the crowded places, and all the precautions to be taken. Like everybody knows, since 1 year we are thoroughly listening to what all precautions to be taken for the COVID-19. So we are telling them, and if they have cough, cold or fever, we are asking them to go for a RT-PCR. If it is positive, we are asking them to consult a pulmonologist in a virtual consultation, or they can directly come to the hospital if they are getting panicked that I am COVID-19, how is my baby, how I'm going to be. Then we are asking them to come to the hospital, so that our team of doctors at Yashoda, pulmonologist, physician, myself, everyone, the radiologist, we are a team of doctors. We are working, we are seeing the patient, and we are analyzing the patient, like whether she's having a mild symptom, moderate symptom, she need a hospitalization, does she need a hospitalization, does she not have need a hospitalization. So any mother who is very away from the hospital, she can take a virtual consultation, she can talk to us, she can even talk to a pulmonologist. If her RT-PCR is done, it is positive, need not get panicked. As everybody knows, whoever is positive, who are at home care, they have to regularly check their saturations and pulse rate and fever. And whenever these symptoms are becoming out of the like if the saturations are coming down less than 94, if a temperature is going beyond 104, 105, I'm asking them to call me or take a virtual consultation, and asking them if the temperatures are more than 105 and the family members are getting panicked, they are unable to control or the temperatures at home, or unable to monitor the saturations, they are not able to understand. At that point of time, I'm asking the patient to come to the hospital and get an admission done for such patients who are and most of the time the family members are getting panicked, and even the mother is getting panicked once they become positive. So a more of a counseling, a psychological counseling is being done for the patients, rather than giving them a lot of telling them what to eat, what not to eat, what you should do, when to sleep, when to get up. All this, more of psychological counseling is needed for the mother, for the husband, as well as for the family members, because they're getting more panicked once they become the COVID-19. And most of the time we are telling them nothing to worry, we are there, we are here. Whenever you feel like you're not able to take care of yourself at home, please kindly come to the hospital, get an admission done, we will monitor you continuously. Those who are having a panic that I cannot monitor myself at home, then we are asking them to come to the hospital so that we can monitor them continuously. And most of the women, they will be asking like my next visit is pending, there is a lockdown, I cannot come. So at that point of time, we are taking a virtual consultation, and we can delay the antenatal visits. Most of the time we will be asking at 12, 28, 32 and 36 weeks. Sometimes I'm asking them to come every second monthly, because they are coming, they have to travel a lot, and most of the time it is being locked down, or sometimes they're not having a public transportation. So we can delay the antenatal visits if she is not a high-risk pregnant woman, if she is not having any of the high-risk medical conditions like hypertension, diabetes, or any heart disease complicating pregnancy. If she's a normal mother without any medical comorbidities, we can delay the antenatal visits for some time. We can ask them to come for a virtual consultation for such mothers. And if she is positive, and we can also ask her to come little bit late for an antenatal visit, only except she has a concern about how our baby is. So an ultrasound which is nearby to her house, she can go and get an antenatal scan done there, and she can WhatsApp to us, or she can go for a virtual consultation, so that we can see the scan, and we can tell how is the baby. And the routine iron and calcium she has to take if she is positive. And all the family members, they have to take care of her psychologically, saying that she will be all right most of the time. And then if the same patient, she's taking care of herself at home, suddenly one day her labor pain started again, she comes, most of the women, they go to the nearby hospital, where sometimes the oxygen availability is also not available. Oxygen cylinder is not there. Sometimes they go to a very small setup, and they want to get a delivery done. If they have very severe symptoms, or if they are she's in need of an oxygen support, at that point of time she has to come to a tertiary care center. So what is a tertiary care center? Like, where all the facilities are available, and a team of doctors are available round the clock, like pediatrician, the obstetrician, the intensivist, the pulmonologist, the physician, cardiologist if needed. Everyone, the team of doctors are available at such a center. The COVID-19 positive mother with moderate to severe symptoms, and who needs an oxygen support, such patients have to come to a tertiary care center, where an intensive care can be taken by the team of doctors. And during her admission, we routinely know what we are going to do for a COVID-19 positive mother. If she's getting admitted, we have to monitor her. We have to do her routine tests, and we have to monitor vitals. We have to monitor her D-dimers. We have to monitor her kidney function. We have to monitor her liver functions, everything. And generally, most of them, they want a normal labor to be conducted. If she is having a very severe symptoms, she is unable to breathe, she needs an oxygen support, at that point of time, we cannot do or allow her for a normal vaginal delivery. Because during the normal vaginal delivery, she might be having a lot of contractions. The uterine contractions, at that she has to put a lot of efforts to push the baby down for a normal vaginal delivery, and for that, mother herself will become strained. So if she is on oxygen support, she is needing a 10 liter of oxygen, or otherwise she is on a BiPAP, we cannot allow for a normal vaginal delivery for such patients. We have to do an emergency C-section for all the patients who come in and labor with an oxygen support of 10 liters, or on a BiPAP, or on a ventilator. We have to deliver by a emergency cesarean section, not by a normal vaginal delivery at all. And most of the people, they will be asking a question like, if I'm COVID positive, will I be allowed to your hospital? Will I be allowed to into your normal labor room, or into your theater? So no, definitely you will be allowed into the hospital. You will be allowed into the normal labor room, and you will be allowed into the theater. If it is an emergency Caesar, we are planning for emergency Caesar, you will be allowed into the theater. And in the theater, we are going to take all the protocols that we will be wearing a PPE, and everyone in the theater, everyone, including the technicians, everyone will be wearing a PPE, and we will be taking care of the patient as well. So during the labor, if the patient her saturations are maintaining above 94, and she's not needing any oxygen support at all, and she's not having any other complications, we can allow for a normal delivery for a COVID-19 positive patient. Along with the mother's monitoring her saturations, monitoring her vitals, we have to monitor the baby as well. We don't know how the baby is going to be during the labor, so a continuous CTG monitoring has to be done for the mother if she is in labor. And many of the mothers, they want a painless labor because normal labor itself is very painful. So they wanted to go for a labor analgesia. So can we give a labor analgesia? Is it possible to give a labor analgesia for a COVID positive mother? Yes, if the same protocols, same everything, if a woman falls into a mild symptoms, and if she's saturations are maintaining well, everything is fine, her D dimers are normal, everything is normal, then we can allow for a labor analgesia as well. And if she is in normal labor and suddenly there is a fetal distress or the labor is not progressing, then we have to we are planning for an emergency C-section. Yes, we have to take her for an emergency C-section, because already we will be wearing a PPE. The same protocols will be taken into the theater as well. And if the patient is critically ill, like she is on a ventilator, her saturations are not being maintained, and at that point of time, if she's in labor, we have to conduct the labor in the ICU itself. We have to, if she's depending on the stage of labor, if she's an active or the latent, then we have to see whether we can allow for a normal vaginal delivery. Most of the time, we have to allow for a normal vaginal delivery in the ICU setup itself. And the continuous oxygen support has to be given, and all the drugs which are necessary for a COVID-19 emergency care, and the drugs which are to be given in the intensive care, which are being decided by all as a team of members, like obstetrician, the intensivist, the pulmonologist, and the physician, depending on the patient's condition. So depending on the patient's condition, if she is if she has to be given all the drugs which are necessary to get her out of that complication, that all the drugs will be given. And once the baby is delivered, the baby is handed over to the pediatrician. In our Yashoda Hospital, Malakpet, the pediatric team is there. NICU, the baby will be admitted in the NICU, even if the mother is in the ICU, or even if the mother is in the is in the critical condition. The baby will be taken care by the NICU team. And then most of the time, or otherwise, if the mother is normal, she wants to see her baby, then we will tell her, because you are positive, you might infect your baby. So only at the point of giving a breastfeeding, putting a double mask, taking all the precautions before handing taking the baby, she has to wash her hands properly, sanitize her hands properly, she has to wear a double mask, and then she has to feed her baby. And immediately after the feeding the baby, she can give the baby to the pediatricians again. Or otherwise, if that is not at all a possibility, that she doesn't want to feed her baby, because most of the mothers, they don't want to feed their baby because they have the panic that they will infect their baby. So she can give an extracted breast milk. She can extract her breast milk, and that can be given in a bottle, and then that can be fed to the baby, if at all during her 2 weeks or 14 days or 14 days of her time, which she has to be away from her baby. And about the babies, if mother is positive, whether my baby will be positive. As I've already discussed before, as long as the baby is in the womb, there is no such no such papers till now that there is a vertical transmission. There is a possibility of vertical transmission. No. So once the baby comes out, if we isolate the baby as soon as the baby is delivered, there is 99% the baby might not get any COVID-19 infection. And then the only transmission to the baby is by handling of a caretaker who is positive, or mother herself who is positive, not taking care, like not washing her, sanitizing her hands, or not wearing a mask properly. That is the mode of transmission to the baby most of the time. And most of the time our pediatricians at Yashoda Hospital, they tell us, like, we will isolate the baby because mother is in active infection, and she's not her 14 days or her quarantine or her incubation period is not over. So it's better to isolate the baby, give an extracted breast milk to the baby. And then once mother's general condition is normal, and once the baby is fine, we can discharge both mother and baby at the same time. And about the vaccinations, I just would like to highlight on this vaccination is, in UK, United States of America, and in Russia, they have already started giving vaccination to most of the pregnant women. The government has given a sanction to give vaccination. As long as of concern in India, our FOGSI, the Federation of Obstetricians and Gynecologists, we are asking any mother who is pregnant in any trimester, she can go and take the vaccination. Most of the time, if she crosses her 12th week, it's better to take the vaccination. The FOGSI is recommending all the mothers to take the vaccination. But why I am not highlighted on the vaccination in this webinar is the government has not given a permission to give, it is not in the protocols to give a vaccination to a pregnant mother. So from the FOGSI, from the Indian Federation of Obstetricians and Gynecologists of India, we are recommending our mothers who are pregnant about 12 weeks can go and take their vaccinations on their choice. But whether you will be allowed to take the vaccination or not, that is concerned with the state health department or the central health department. So let's see, let's hope for the days to come that where the government can sanction the vaccination for all the pregnant mothers so that they can have their safe motherhood and they can get out of this panic condition once the vaccinations will begin. And as an obstetrician, I also have a opinion that the government should sanction or give a permission to give the vaccination for all the antenatal mothers to be, to be on a safer side. Thank you, everyone. Thank you very much.
Yeah, thank you, ma'am. That was really wonderful talk. So almost you have touched all the gray areas of COVID-19, which is regard to the maternal health.
Thank you.
Thank you, ma'am. So now we have an young and adult pediatrician, so who is treating and dealing with all the COVID patients at Tier 2 city. Dr. Rajesh, could you share your experience on COVID-19 patient? So what you have seen at your practice. Dr. Rajesh.
Yeah, thank you, my dear friend Kiran. So it is now everybody's concern and media concern is third wave, and everybody is bothering about children being affected in third wave. So what my clinical exposure and clinical experience is, nowadays we are seeing more number of COVID positive patient children, because I think this is because of more number of tests being done nowadays, because as we see in Maharashtra, we had a news that more number of cases have been recorded. So this caused panic in here also, and they started doing more tests. But among these tests, what we are among our cases, most of the children are being mild and having only mild symptoms only. And those some children, these children we are treating in OP basis, and sometimes we are monitoring with the help of local doctors or local sisters, whoever it may be, who are in close concern with the patients, like home-based facilities. And moderate patients, we are admitting them, and severe cases mostly we are not seeing, but sometimes we are getting severe cases also. And severe cases only 1 or 2%. That too in what is the experience is, we are not seeing in our settings most of the severe cases. We are getting from our friends reviews that we are getting severe cases only. MISC, that is into settings only. So very few are needed with IV immunoglobulins and steroids and enoxaparin, like that. And otherwise, mostly we are seeing mild cases only. What we are giving only paracetamol and adequate hydration. We are doing all the investigations which are needed, CVC, ESR, CRP, and sometimes if needed, we are going for other tests like procalcitonin and D-dimer and interleukins and LFTs and RFT, renal function tests as such. But sometimes in whatever we are getting in moderate cases is those who are having with respiratory rate more respiratory rate. That is for age-related respiratory rates for less than 2 months. If we are seeing the respiratory rates, and if respiratory rate is greater than 16 less than 2 months, it is significant, and 2 months to 1 year, if it is greater than 50 per minute, it is significant, and up to 5 years, it is greater than 40, it is significant, like that. And along with this, if there is any procalcitonin, if it is elevated, and if there is any D-dimers are elevated, if there is any fibrinogen is elevated, we are treating accordingly. That's our experience. Mostly we are seeing mild cases, and even we are not giving antibiotics. In moderate cases, we are giving IV antibiotics. Along with this, very rarely we are giving remdesivir in our setting, and but steroids may be needed in mild settings. Steroids, this is in severe MIS, it may be needed in high doses also. It's like 10 to 30 mg per kg methylprednisolone we are giving, but in mild cases it is very low, like 1 to 2 mg we are giving. That depends upon the situation.
Thank you, Raji. Then I would like to ask one more question. So,
Yeah,
what
yeah.
is your experience regarding the recovery rate when COVID being affected to the children age group?
Recovery rate is very excellent as such, Verma, and we are not seeing many deaths. We are not at all seeing many deaths, but very in some settings only we are reporting deaths, but most of them are recovering very well.
Okay,
Very
okay,
few complications. That's it.
Thank you, Raji. Thanks for spending time with us.
Yeah, thank you.
Srinivas,
Thank you,
sir.
Verma.
Thank you.
Yeah.
Srinivas, sir. So we have few questions over here.
Yeah.
So can we take 2 or 3 questions?
Yeah, sure.
Yeah. First one is, what is the possibility of third wave of COVID-19 in the coming months?
Definitely, there is high possibility of having a third wave, because the rest of the population who are not infected, they may get. But coming to the pediatric population, yes, again, if the children are not infected, there's high chance of getting infected, because the only group which is left when you see with the statistics, so there is high chance of getting a third wave. But let's see, when you come to the severity, I'll still say that throughout the statistics in the India, 90 to 95% are like mild to asymptomatic. So I don't think we need. But once you see the large number of children getting infected, you see the number of children getting with severe and critical disease also increases. So we're ready for that to treat and identifying it. It's a very good prognosis even after identifying early, because giving an IVIG or steroid, most of the child is presenting with very bad LV function, like less than 30 or 40. With 2 to 3 doses of methylprednisolone, they're improving very good. So it's only identification. No need to worry or panic for the next waves even.
Okay. Josna, ma'am.
Yes,
So
sir.
I have one question for you.
Yes, sir.
So can we use remdesivir and steroids in COVID-19 patient who is pregnant?
Yes, sir. As we discussed previously, remdesivir is an indication to be given in a pregnant patient who is admitted in the ICU, is in a critical condition where she has to, where there's a increased cytokine storm, where the inflammatory process is going on. At that point of time, as saturations are not being maintained, day by day, her saturations are getting they're becoming more less. She's need a lot of oxygen, or she has to be put on a BiPAP machine for such patients. And when CT chest is done, if her CT chest is being done, and if her chest is very bad, I mean, if she's in the CORADS 4 or 5, then at that point of time, we have to save the mother's life. The point of admitting a patient, admitting a mother who is COVID-19 is to save her life. So for saving her life, injection remdesivir, if we give it to a mother, it is not a contraindication during the pregnancy. It is only a life-saving drug.
Yes, yes. So we have one more question for you, ma'am.
Yeah.
So a breastfeeding mother who is affected by COVID-19, is breastfeeding advisable or not?
Definitely, sir. She can, but the thing is, she has to take all those precautions. I mean, like she has to wear a double mask and she has to take all this hand sanitization and all those things. But we don't know how, even after taking all those precautions, maybe the baby might acquire that infection. So Dr. Srinivas has to highlight on that, whether is that that breastfeeding can be given to the baby if mother is positive by wearing a double mask and sanitizing the hands.
See, throughout the world, there is a saying that there is no replacement for the breast milk. So I absolutely say that every baby should get a breastfeed, because it's we call it as a first vaccine. Generally we call it as a first vaccine. Breastfeeding is a first vaccine. Definitely, it will help the baby to come out of it. Even as we see the statistics, that even after getting positive neonates, they're doing well. Very rarely we see pneumonia in neonates even. So the universal precaution, what you call the mask, hand hygiene, or expressing the breast milk, taking the baby when required, not all the time, rooming when required, placing the baby in the other room and giving expressed milk after the hand hygiene, cleaning the bottles regularly, and feeding the baby often will definitely doesn't transmit that, because we keep practicing the same in our unit. So we advise the mothers, if it is possible, get an attender, ask them to help in then expressing the milk, and give the milk to the who are taking care of the baby, and they can feed. So this way, because most of the route we are seeing is respiratory route. So if you avoid the respiratory route to the neonate, so the infection rate coming through breast milk is very, very, very less.
Yeah.
No documented evidence which we see like directly baby is getting infected through breast milk.
Yeah.
Yeah, good.
It's advisable.
So it's always advisable to give breastfeeding unless otherwise it is contraindicated.
Yeah.
This is the last question, sir. I have many more questions, sir. It is the last question.
Yeah.
So what would be the precautions in case third wave comes and affect the children?
So this is like again the same thing. So we need to, as a like tertiary unit, we are ready to face that, even if it's like in the worst case. So always believe in that if it is in the worst case, we are ready to handle it. Like, because we need like a few ventilators, because the respiratory component in the MISC is very less. So they may require minimal to moderate oxygen requirement. So the most important is drugs and having enough number of beds in the PICU and HDU. So where we require frequent monitoring. So strengthening number of beds is more important if the number of the missed cases are increasing, and addressing it early, preparedness. And I meant getting the IVIG, because we always see that whenever some drug we needed, it will going to be like high demand. So better to be prepared and go with the IVIG, enough number of IVIG doses, because it's the only drug which we give in pediatric case other than steroid. So preparedness is the best thing we can do, because wave we don't know whether it will come or not, but preparing for it is always best. So we are ready to deal with the things if it's going to bad.
Yeah, exactly, sir. Preparedness is the most important thing now. Thank you, Dr. Josna ma'am. Thank you, Dr. Srinivas sir. Thank you, Dr. Rajesh, for spending time with us and clarifying all the doubts. Okay. Thank you, Honorable.
Thank you, Dr.
So with
Kiran.
this,
Thank you, Srinivas.
so with this we conclude our webinar.
Yeah, thank you.